What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
Good morning, everybody. This is Dr. Zach Baker of Rehab to Perform and R2P Academy, and we have on with us today a special guest who we have not heard from, at least in this format on the podcast, Dr. Corrie Jones, and she is PT at one of our locations, actually our headquarter location in our Frederick office. She's been with us for a few years now, as somebody that Josh and I have known for over a decade, as her and Josh were in the same physical therapy class. She'd done some very cool things early on in her career. Fortunately, moved back to the DMV area, and that was kind of when she got on our radar as somebody that we needed to get into our ecosystem at R2P. And she's done nothing but impress since she's been here. She's phenomenal with patient care, but even more phenomenal with regards to clinical education, demanding and promoting clinical excellence, and really just taking a large leadership role in regards to training up not only our students, but our entire staff and professional colleagues at R2P and within the profession. So, Corrie, thank you for coming on. And I know the topic that we wanted to talk about today was, what the heck do we do when our patients don't progress? So thank you for coming on. And what do we do when they don't progress?
Yeah, I appreciate you having me on. This is a question that I get asked a decent amount by my students. And then, of course, no matter who you are, no matter how great you are at PT, it's going to happen where you just don't have patients that are quite progressing the way you would expect them to. So it's worth kind of chatting through a couple of ideas maybe that you would have, that I would have to kind of put out there and let people think through so that whenever you do have that happen, you have some go-tos and some ideas as to what to get after.
Definitely. And I think there's a variety of ways that you can go with this conversation. And it's not necessarily, an organizational algorithm of like, all right, we attack this and then we attack this and we attack this. But I do think if we at least have some overarching concepts to keep in mind, it allows you to have a checklist of, all right, have I touched on this? Have I addressed this topic? And then context and situation is always going to steer kind of the order, the sequence, and the depth of which you go into that. But things that I always find myself thinking is, have we even created any expectations within this plan of care? What do we think is normal? What does the patient think is normal? And have we had that conversation? Another thing that always comes to mind is comparison. And are we not progressing the way we think because we're comparing this patient to a former patient of ours? Or the patient is comparing themselves to a friend or a teammate or a family member who had a similar injury that played out a different way. And then the last one, and I think this one's really important, and probably the one that personally I am the most guilty of is, am I ever taking the time to step back and look at this from a different lens? Or am I getting a little tunnel vision? Am I getting kind of set in my ways of, hey, you know what, this usually works, so I'm going to go down this rabbit hole. And then I get too far down that rabbit hole and realize maybe I was wrong from the beginning, or maybe we could have deviated from that from the beginning. So those are kind of the three big directions that my mind goes. Corrie, do you mind just kind of unpacking some of those for us?
Yeah, for sure. I would agree 100%. I think one of the biggest things is what you said, so expectation and perception. So those are two things that we talk about a lot, like on the How to PT course. It's taking two different contexts, right? So the first context is whenever you're talking through expectations, you have some as a clinician, and then your patient has some as a patient. So trying to discern where everybody's coming from as far as expectations is huge. So, for example, if I have a patient who's like, man, I really thought that I would be running by now. Like, why am I not back to running? I've gone through these steps. The doctor said, I had a certain amount of time that I was going to have before I could start running. Where are we on that? Like, if you start seeing frustration there, that's because they had a certain level of expectation. So it's not just return to run. It's not just healing time frames, but just overall, it's trying to figure out expectation-wise when you come to therapy, what do you actually think is going to happen? Is it, I have expectations because of past experiences, so I've been in another PT place before, and here's what they did. Is it expectations because of who I've spoken to, like my friends, my family, my doctor? Or is it expectations because you said something in the beginning that now you're kind of changing your mind a little bit? So really, really clear communication becomes like a huge deal.
Yeah, and I think one thing to piggyback off of that is you had mentioned not backtracking off of something you said early and people coming in with certain expectations. One thing that I try to really unpack at the eval is where have they got their information from? And you had mentioned one example being like, oh, I should be running or I should be returning to play, especially with post-operative patients, just because I don't want to say the stakes are so high, but there's been such a significant event that's taken place. And not to downplay, a pulled muscle or an ankle sprain or something that's a shorter time loss injury, but you commonly see it with post-operative or longer-term rehabs where there are some relative expectations of general timeframes of when things will happen. And where I have found that I've either put my own foot in my mouth or just didn't speak clearly enough is not understanding what has already been told to the patient. And I always try to ask them, hey, you just had your surgery, you just had your 2-week follow-up with the physician. Have they mentioned anything in regards to big picture? What were they laying out as expectations for when you're going to start playing again? Playing again meaning competitively. Like you're on the field, you're on the court, you're in the pool, you're doing whatever, and you are competing again. Did they tell you a year? Did they tell you 9 months? Or did they tell you it depends? And these are the things that it depends on. Did they tell you when you can expect to start running again or when you can start working out, like really working out in your old environment again? And if they start saying answers like, yeah, they told me I'm going to go back to them around the 3-month mark, and around that appointment is typically when I start to run. But it's going to depend on if we do X, Y, and Z in PT. Or they told me that I'll probably start playing roughly in a year, but it could be a little sooner, it could be a little bit later, and it's depending on what information you tell them with the testing. When they have that conversation, awesome. I already know it's been communicated to them. I'm not contradicting what may have been said. I'm on an expected time frame that's consistent with the other healthcare members on this team and that are part of this plan of care. The other thing it allows you to do is not contradict somebody or have to take back what you say. And a lot of times that happens when maybe they have had those really good conversations with the physician or whoever else is in that conversation, but what if it doesn't match up? And what if they're telling them like, yeah, you'll be playing at 6 months post-op ACL, or oh, you can run whenever you feel like it. It's like, okay, well, I gotta make sure that I know what I'm working with, and maybe there is more or less to this injury than I'm aware of, and maybe I need to reach out on that. And I don't know, how do you address those early interactions of just getting the whole kind of like plan of care team on the same page?
Yeah, I think it's really important, first, what you said. So I'm at the eval, I'm asking the patient, like, literally, what are your expectations? What are you looking to get out of therapy, and really going through those goals? Part 1 being their background, so you're talking patient context so far. Part 2 being your context as a therapist. So everything that you just said, and then in addition, I know as a clinician, here's what conversation I had with the doctor, or I need to have, because maybe it is just a phone call to get on the same page. Part 2, tissue healing times. Like, are you thinking through that? Do you actually know what you are expecting from tissue healing times? When do we protect versus when can we push a little? Part 3 being like objective measures. So are you making your opinions and your expectations based on what you're actually seeing with the patient objectively? Or is it just like, oh, like, I feel like you're doing better and I think you're progressing well. I don't actually have a structure to see if you're ready, but we're going to go for it and try it. Way better option would be, let's test. So I'm not using opinions or anything like that, but I'm actually testing to see how are we moving, how are we progressing. And that's not just at initial eval, like we're talking about, like, first thing, but even like progress notes. Like, I honestly know that a lot of us hate progress notes. They are long. There's a lot to write. However, they're actually huge because you're repeating objective measures. You're asking the patient where they're at mentally. You're asking the patient where they're at physically. We're trying to actually see, is this a place and is this a time where we can dive into a little bit more? Or, yeah, like, they're really not progressing like I expected. So let's go back. Let's retest. What is still not lining up? Are there range of motion issues that I saw but I didn't really dive into? Are there strength issues that you're like, yeah, like I know you want this to be faster, but I cannot speed up strength building. Like that is a physiological process that takes time. Or is it just something that, yes, we were prioritizing these other things, and actually we just need to keep doing those, but maybe we start prioritizing something different. So I think one of the biggest things is like, can we see what the patient's expecting? Can we look at ourselves and see, hey, we're expecting some of this as well, so that everybody's on the same page there, but being willing to adjust, I would say. So if you have a doc, if you have a parent, if you have a coach, if you have a strength coach, that maybe you're on a little different pages, you don't have to come with them with opinion. You come to them with numbers or with assessment or something that you've actually visually seen. Sometimes with an athlete, I literally can video different movements, say like, hey, this is kind of why I'm saying we're taking a little bit of time. Or we happen to be lucky and we have some volled force plates. Here's what we're seeing on the force plates. This doesn't show me that you're ready to move on from here. And I think the big thing is just making sure you have those battery of tests so that you as a clinician, your context, you're saying, yeah, this progress isn't quite where we need it to be. Let's shift. Or like, no, actually, like, I think you're ready. Like, let's move forward.
Yeah, and I think I'm glad that you touched on progress notes. And I know they can be, at least like the documentation or the process of going through them can sometimes be tedious or just logistically challenged, depending on how your workday's going. But in my opinion, it's really what separates us and our profession from some others in regards to delineating roles. And I think a lot of times we get really caught up in like, all right, I want to be the exercise guy or girl, or I love taking my person through workouts, and that's cool, but we need to know what we're working towards. And you don't know what to even program for them or what to put into your plan of care if you're not, one, doing a really good initial evaluation and identifying what impairments or influencing factors are there that are impeding movement or influencing movement or ability to demonstrate some of these more kinematic skills with the individual, or to even validate that what you're doing is any good. And it's great to have a good eval and establish a plan of care, but we don't know if it's working until we recheck some of those things.
Exactly.
And I know we often subjectively ask, like, hey, how are you feeling? Did you have any issues after last time? Are you making any improvements? And they may tell you yes, or they may tell you no, but we also need the objective side of that. And it can be validating. Somebody who is very pain-focused, or maybe they're just task-focused on one thing, and no, that one thing has not gotten better. But guess what? If I can present them with a progress note of these other 5 measurable things have gotten better, you can help kind of change their mindset and change their trajectory a little bit. Progress notes for me, I find myself getting a lot of value for them when I'm taking somebody through a workout, and it's been a few weeks and I'm like, gosh, like this seems repetitive. I don't know if it should feel repetitive. And I don't know if it's just because I've kind of lost track of time and I haven't mixed things up. Or like you alluded to, maybe it's a strength deficit and volume and repetition and consistency is what we need. But I feel more comfortable being repetitive if I have something backing that up. But Corrie, can you touch a little bit on kind of the concept of the eval and the progress note? And if you get, a couple sessions or a couple weeks in, or you do that progress note and you don't make change, what are things that you're keeping in mind in regards to like, how can we reprioritize efforts or reevaluate how we should be allocating time to different things? How much stock do you put into like, all right, this is just biological healing time frames versus these are more movement-based things that we may be able to more readily influence? What if I was taking a certain approach? How do I know if I should go a different way? How do you unpack all of that? And I'm sure you can explain that in 30, 45 seconds?
Yeah, right. Exactly. So there's PT. That's what our profession is. So I think the big thing there, it kind of comes back to something you mentioned a little bit earlier, being eclectic. If you can have a big bag of tools so that you can pull different strategies out of your hat, that's huge. So it's really easy sometimes to get pigeonholed, right? You're following the same people on social media. You're talking to the same people. You start thinking like everybody else. But it's kind of better if you can be kind of like a generalist, right? So your wide breadth of knowledge or information or strategy really can pay into something like this. So let's say that you're really diving in heavily into manual stuff. So maybe it's more of like a low back pain, not really sure what's going on, insidious, and you're going McKenzie, right? So you really think like, hey, this looks I don't know, discogenic. However, you're working on this and you're like, nothing's changing. Like, what's going on here? And here, if you just kind of hammer like, this is what I know, and I'm just going to keep going after it, then it's almost like the definition of insanity, right? Like, I'm going to do the same thing over and over and over, expecting different results. It's just not going to happen. So the big thing about being a generalist or being eclectic is, can I veer whenever I need to? And then part two of that is, the only way I can veer treatment strategy-wise is back to what you said. It has to be an excellent diagnostic in the beginning. So if I do my eval and basically I'm like, okay, so here's a hip greater trochanteric bursitis maybe. I've seen this 500 times in my profession and in my practice. I know that usually that means single leg instability and hip strength deficits, right? So I'm just going to like do a real quick eval. We're going to dive into a couple of things where we're loading that single leg and see what gets better. If I don't actually diagnose, let's say that they have 4 different range of motion deficits that I didn't even look into. Rotation in the trunk to the same size limited. They don't have any midfoot pronation. So how am I going to get on single leg and have a stacked leg if I don't have these range of motion capacities to then load? So it's kind of one of those things where you can think you're strategizing the right way because of what you've always seen, or take the time, do an excellent eval, diagnose well. Now, if I'm like, I can still strategize towards strengthening in a single leg. However, whenever things are not going as I expected and the patient's not progressing as I expected, can I continue what I'm doing to pursue those deficits that I've seen and tested? And in addition, hey, diagnostically, let me look back at my eval. I found some range of motion deficits. I found some joint mobility restrictions, and maybe I saw something else that I want to actually veer to and start emphasizing a little bit more. Suddenly, we have this cool breakthrough. The patient's moving better. All of a sudden, the stability neuromotor control gets better. And guess what? Neuromotor control gets better. Now I can load. So all of a sudden, with a 1-2 week strategy, I've jumped like what I thought would take another month because this patient just isn't getting better. It's funny because like your first instinct is to start saying, well, what's this patient doing? Are they not doing their homework? Are they, not modifying things the way they should? And yet before like going there, maybe it's really looking at, was my evaluation good? Can I reprioritize? Can I veer? Do I have the capacity to shift? And then just emphasize other things.
Definitely. And I think you can look at shifting mindset on an approach on a macro level or on a much smaller scale as well. And you talked about, all right, we have this low back pain patient, and how much do we prioritize patient education, activity modification? How much do we prioritize symptom management and whatever means necessary for that? How much do we attack movement deficit, so like true mobility impairments, versus movement quality versus just building strength? And you can think about how much do we allocate different times towards each one of those buckets. And maybe in the beginning we thought, look, this is just poor movement quality, and we need to coach up movement quality. And then like you alluded to the single limb stance reference with trochanteric bursitis, well, maybe that movement quality is impeded by mobility, and they cannot execute this task because they don't have either appropriate ankle mobility, or they don't have good foot and ankle stability, or maybe they don't have the strength to carry out this task. And that's where we need to just reverse engineer one step further and figure out, what are some of these more basic, maybe kinetic qualities that are influencing kinematic expression of movement? The other thing that we need to do is just be variable within an approach. And an easy example of this is like, I currently have a post-op ACL patient where I know that I want to restore flexion and extension in month 1, and she's 2 weeks out. And I know that I just need to restore flexion, but I don't really care how I get there. And I don't care if it's doing a heel slide, or if it's having them sit over the edge of the table and use their other leg, or myself as the PT to range their leg. Maybe it's lying on a back and doing a wall slide. Maybe it's doing a prone knee bend. There's a variety of ways to do it, and I don't really care how we do it as long as it's safe, it's tolerated well, and it's yielding results. So it's funny, I had them just with their feet up on a ball, like a big stability exercise ball, rolling the ball in and out. And this person was getting like 40 degrees with every roll, like minimal motion. But she was doing other things that demonstrated the ability to do more than that. So then had her sit up, come to the edge of the table, and she was able to let her legs just dangle completely off the table at a 90-degree knee angle. Then we were able to stand up, and we could put her front foot up on a plyo box, and she was able to gently rock in and out close to like 100 degrees of knee flexion. So I think sometimes we just need to change context. And it was funny when I asked her, like, why couldn't you move your knee back and forth with the stability ball? She thought the whole purpose of the exercise was to dig her heels into the ball and activate hamstrings. I was like, oh, you know what? This is like the 7th ACL I've seen today. And I just gave her a ball and told her to roll it in and out. I didn't really tell her what to do or what the purpose of it was. So sometimes if you're not getting the result that you want, it may not mean that you're in the whole wrong ballpark and that you need to go, oh, it's not mobility, it's strength, or it's motor control. Maybe you just need to change context within that individual exercise bucket that you're working within.
Yeah, so let me jump on that real quick, because the interesting thing about that is we were talking about strategies. So like maybe it's different CEU courses you've taken or different lenses you've had in the past. Part 2 of this, every student that I've had knows this. My like little soapbox I like to get on is every patient's a neuro patient. So if we're talking about lenses, here we have an orthopedic lens, right? Or maybe like a kinesiology lens. We have a neuro lens. We have a cardiovascular pulmonary lens. We have to make sure that we're kind of seeing each of these body systems so that we're also not like, oh man, like orthopedically, they are not flexing that knee. Here, all that ball does, rolling with stability, that's that reciprocal inhibition, right? So like we're using a neurological concept without having to explain that to the patient. We're saying, let me activate hamstrings so the quads stop protecting and guarding so much. Now all of a sudden she has knee flexion. So I think that's another way you can shift, right? Like when people aren't progressing the way you expected, maybe you're like really, really, getting after biomechanics. And maybe biomechanics, yes, you can dive into that, but what if there's some neurological principles that I can dive into? This is a whole nother lens or a whole nother prioritization that now all of a sudden I'm like, oh man, I'm moving differently. There is a smaller load or a less intense activity that is actually either more comfortable for the patient or just different. Like you said, change the context, make it a little bit more variable, and all of a sudden we see progress. So even that, being able to shift your lens as far as like how you're looking at someone, that's like huge. So I love that example. That's perfect.
And then, all right, so we've evaluated this person. We've taken them through our initial plan of care based off what they reported to us, what we found with our evaluation. We get 3 or 4 weeks into it, we do a progress note, and we realize not much on paper has changed. Subjectively, they're not reporting a lot of change, and they're not overly thrilled with the direction things are going, but they're still bought in, they still trust you, they still believe you. They're just not thrilled that, hey, it still hurts doing X, Y, and Z, and all of these different functional tests that we did that the exercise is supposed to help with, they're not really helping either. You've changed your approach, you've gone at it through a few different lenses, and you're just kind of stuck. But what are our other options there as a clinician? And I know we have the luxury of being in a relatively large clinic. We have other providers with us. We live in a great area in the DMV where beyond PT, there's other providers out there as well. What are some things that should be going through our head if we feel like personally we've exhausted our abilities with this individual, with the current information we have? How do we deviate from there?
Yeah, so I would say definitely 2 things. One is like you got to know your limitations, right? So we have to know when to refer out. So I've seen this patient for 8-10 visits. They don't see change. We kind of see change even though they're bought in. There's not a lot going on there. When do you refer? So that's kind of like our number one priority, right? Like safety. We want to make sure that our sessions are effective. We want to make sure that there's actually benefit and change here. So I guess that's one big thing, like know your ego and make sure that if you are not seeing change, you know when to refer out. So whether it's back to wherever the patient came from, or to a different MD. So I've had a patient who she looked like an orthopedic problem in the beginning. We started seeing a couple other things that kind of looked a little bit more neurological. In the end, we did a couple of extra vascular tests. Here, she needed a vascular surgeon. So it's kind of like make sure that, again, if you're not seeing the progress you would expect, make sure you're looking to refer when necessary. Part 2 of that is not only referring to medical capacities, but also maybe they need to go to counseling. Maybe they need to talk to someone. Maybe they literally just need to spend time with a good friend, like sussing out this like annoying pain, right? Like just talking to somebody. I think it was Dr. Sanjay Gupta talked about the absolute best thing that you can do if you're having a hard time progressing is go for a walk with a good friend and talk about the deeper things in life. Because walking is something active, talking with a friend is diving into psychological things where you can kind of suss things out and think through things. And talking out loud, now you actually have to like walk through. So do you need to refer to a psychological counselor in some way, shape, or form, or do you need to kind of like talk to this patient about what's going on in their life, and are there other things that they can address in themselves? Part 2 of that being, if it's not necessarily a referral, is it asking a mentor for help? So I think it's huge, number 1, to seek out more mentors, but number 2, if you don't necessarily have a one-on-one mentor, who are you going to with these questions? So do you at least have like, hey, I have 3 or 4 people that I'm in contact with, whether it's a peer or a mentor or somebody just that has more experience than you, that you can say, hey, I have a quick question, can I drop this to you? Whether it's, you know, a DM in messages or whether it's more so a personal call, just being willing to reach out. Like you said, I feel so lucky. We're in like the biggest office for RTP, and we have so many people that I can just be like, oh my gosh, this patient is not progressing. What would you be doing here? Or what ideas do you have? So I do feel like we're a little blessed to have all these like amazing people around. But part 2 of that is like, you have to have the humility to even ask, right? In order to collaborate, it requires humility. So can I actually like, again, come to the end of my ego, come to the end of myself and say like, I actually need somebody else to look at this and talk me through this. If you talk to me about one of the top like things I'm looking for in a good clinician, it's just humility. And sometimes we need to check each other. Sometimes people need to nudge me. Like, what are you talking about? Like, you need to be humble and like back off a little bit so that you can learn from other people. If you have an open mind and a growth mindset, I mean, it can change a lot of things, especially when your patients just are not progressing like you think. So if I'm willing to reach out to somebody else or to refer, those 2 things can really help me like, I would say like open my mind to other options and other ideas, and back to what you said in the very beginning, other perspectives. My perspective is limited to my experience, but all these other clinicians have different CEUs. They have different experience. Maybe they've seen this diagnosis more than me, but all of these things can lead back to, hey, knowledge is shared, right? Anything I've ever learned in my entire life came from either a teacher, a parent, a friend. Like, it always comes from somebody else. Same in PT. You have not come up with any original ideas. You've learned it somewhere. So how can you gain more of that shared knowledge? By just asking someone.
Definitely. If you want to talk about building a company culture as well, you talk about humility, but also it validates your colleagues and your other people on your staff. And if somebody knows that, hey, it's okay, Corrie's really smart and Corrie's asking somebody for help, that shows a commitment to lifelong learning. It shows a commitment to humility. It also shows a commitment to utilizing your other resources on your team and actually thinking enough of them to ask them for advice and then utilize that advice. And I think it means a lot. Like if I'm a young clinician and I have another member of staff, especially somebody who's a more tenured member on staff, asking me for my opinion, I feel like a part of the team. And I feel like I'm operating within a team. The other thing it does, it makes that person more likely to ask others on the team for help when they're struggling. And you create this just commitment to learning. You create a very cohesive environment. In regards to referring out, another thing that comes to mind and something that I try to prep patients for at the eval, hey, you're coming in for this knee pain or this hip pain. Based off what you're telling me and how you're presenting, this is what it looks like diagnostically. This is what standard plan of care is for it. And based off your presentation, this is how I think we should allocate efforts and spend our most time. These conditions typically take X amount of time to heal. These impairments typically take X amount of time to start seeing improvements. So we're going to recheck these measurements today at this date. I anticipate you to move pretty linearly through this, or I anticipate maybe a slow start, and then we'll start gaining momentum at 2 or 3 weeks, whatever the context is. If we don't see improvement, this is what we're going to do. And I have had some of my best patient experiences have been the ones where we actually didn't make a lot of progress with PT initially, but they knew what the exit strategy was at that 2-week mark, at that 5-visit mark, at that month mark. And when I said, hey, I think you should go see Dr. So-and-so, or I think you should tap into this, and reassure them that, look, this isn't a red flag medical issue that you need immediate care for. We've ruled that out for. And even if you go to them right now, they're probably going to tell you to work on X, Y, and Z in the meantime. So let's knock this out now. If you want to be proactive, set up a visit like 2 or 3 weeks from now with somebody. It's probably going to take that much time to get into them anyways, and I don't like wasting time of doing a month of PT, realizing we didn't make progress. You try to get in with the ortho or the neurologist. They're booked out for a month, and now we're 2 months into this thing before you're getting any real answers. So I think when you get to a point in your career where you're comfortable enough recognizing which ones you should really see improvement with versus this might be like a 50-50, maybe they're a direct access patient, and you're just trying to line up all of the boards on the chessboard in a manner that puts everybody in the most efficient, streamlined way for success. Patients appreciate that, and they get less irritated when they get 2 or 3 weeks into a program and they haven't made progress if they already know what the next step is and they know that the preceding steps were still beneficial and probably necessary regardless of what that first step would have been.
Yeah, and to add to that, so exactly what you said, sometimes patients think that all the progress is going to be exactly linear. Back to expectations, is that really a true, honest expectation? So sometimes I just have to kind of educate people, hey, this is not a linear process just because of the way the body works and life gets busy and all the external factors that influence pain. So educating them on the fact there might be ups, there might be downs, but the goal is this like gradual progress. So I think that's the other thing. Yeah, like what are they expecting rehab to look like? The better you are explaining the rehab process, I think the less surprised people are like that. If you either have to refer out or if you have to shift strategies or you have to change what you're doing because you've already told them, we're not going to fix you. Like, you're not making promises. You're actually just explaining the process. The process is we see these deficits or these limitations. We're going to try to address them in this way. We can always modify. So if you're really good at explaining that rehab process, there's way less fear, worry, concern if there's not unexpected progress happening. Yeah. So, yeah, that's huge.
And I always tell students, I've been practicing for 11 years. I've had, I don't know how many students over that time. And when I came out of school, I was exercise science, CSCS certified was my background. Prior to PT school, I had a lot of sports, strength and conditioning oriented clinical experiences. And everybody I saw, I stretched and strengthened. Like, that was my approach. We just did a really well-balanced strength conditioning program with respect to whatever their orthopedic condition that they were rehabbing. And most of them got better. Then I started taking some dry needling and manual classes. So now I started needling and doing hands-on work with everybody. A lot of them got better. Then I started taking just a wide variety of Con Ed courses, some with more of a musculoskeletal lens, some with more of a neuro lens, some with more of a biopsychosocial lens. And a lot of those people got better. Like, my success rate hasn't changed. It's always been relatively the same from year 1 through year 11. What I have found is I'm not having as much of the unnecessary conversations or the unnecessary inconveniences with the rehab process. And I think that's really like the evolution of a career is you're typically going to get proportionally a lot of the same people better from start to finish. You're going to do it in a more efficient manner. It's going to be more comfortable and more palatable for the patient. And it's going to be something where it's just there's less time wasted because you know how to best allocate efforts and you know what to avoid because it happens. And you realize I'm never going to do that again. I'm not going to waste 2 weeks waiting for X, Y, and Z or waiting to have this conversation. I think that's really, for me, the evolution of my career has been not necessarily better success with patients, but less time wasted with patients. And Corey, we've talked a lot about what we as clinicians can do to modify. Just before we close off here, are there any more patient context related things that you think are important to hit on to kind of close out this conversation?
Yeah, so I think the big group of things that we always try to hit: nutrition, sleep, making sure that you're modifying the activities that you're doing that are irritating the issue. We are so lucky to have nutrition on staff here, but being willing to refer there as well, or refer to a sleep coach or something like that. Those blocks are not small. They're not talked about as much as the biomechanical or kinematic things, and yet they are just as influential. So I think that's like huge, making sure that that's in your mind and it is a conversation with every patient. So that's like one of the big things. And then I always say my secret to healing, because if I could speed up the strength building process, I think I would win a Nobel Prize. I'm not quite there yet, but like maybe someday someone will do that. In the meantime, the only thing I have truly seen that speeds up the process is gratitude. It sounds silly, but it's that looking again through that biopsychosocial lens, if you can have gratitude, be thankful for the progress, every time, like you said, you hit the progress notes and you're like, sweet, A, B, and C are all better. That's exciting. On the first time that your ACL or total knee gets around on a bike, boom, big celebration. The more you can be celebratory and like really pointing out the small victories, it's kind of crazy how much that really does help get somebody out of a pit or out of a hole of worry, anxiety, I'm not getting better like I thought I would. The more gratitude that somebody can come up with, the more they start seeing the positives. And then it's weird how the body responds to that physiologically. So I think that's one of the things that I try to encourage. Not everybody's going to like be a journaler and journal gratitude every day and whatever, but can you start the visit with what's gone well this week? You know, what are you thankful for that's really changed this week? Or like even like non-PT, what in your life is going well this week? Because it's tendency with the news and with everything else to be so negative. And yet the first time you can start turning things positive, when they come to see you, instead of saying, how's your pain and what's going on with this? Their mind is starting to actually be turned to, okay, I'm going to see Corrie today. I really need to be able to tell her what has changed and what has gotten better. So they start looking for positives. All of a sudden you start looking for positives, you see positives and you start seeing this progress. So I'm not saying that there's always going to be a change, right? Because sometimes there's structural things involved. Sometimes there literally needs to be a referral. But there are many times with my people that are just struggling where if we can direct that positive mindset and just really have them start thinking on the things that are better, do things start turning around and we get this little dip in progress. So helpful there if you have that communication skill to start saying, every time you see me, I need you to tell me what's better. And it's kind of a cool thing to actually see if you start implementing that.
Yeah, that's awesome. And that is very, very good advice. Corrie, appreciate your time. This will not be the last time that you are on this podcast. So if you're listening, stay tuned because we will have her on a little bit more regularly in the future, deep diving really into just patient care and how do we get the most out of what we have to offer and leveraging some of our other resources. So, Corrie, appreciate you coming on today and thank you for your time.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.